This is the biomechanical examination for the foot and ankle. So the first one we're going to be doing is some joint mobility of the talocrural joint. This is a convex on concave joint, and we're assessing dorsiflexion, so we're going to be doing a posterior glide. So I am stabilizing this joint proximally, and then I am moving distally the talus, assessing for hyper, hypo, or normal mobility. I'd say this patient has normal mobility of the talocrural joint. Next, for assessing rear foot inversion, what we're doing is we're taking this patient, so we're stabilizing still proximally and bringing this patient into inversion. I do notice some ligamentous laxity with this patient as we go into inversion. As we go into eversion, this patient has a firm end feel for rear foot eversion. For midfoot varus, what we're doing is we're stabilizing at the calcaneus and then moving the midfoot into inversion. This patient has a lot of mobility with midfoot varus. As for midfoot valgus, this patient does not have a lot of mobility. When assessing the first metatarsal, what we're going to do is we're going to stabilize Mets 2 through 5. We are then going to assess the mobility of the first Met. This patient has very good mobility of the first Met. And then for assessing the first MTP dorsiflexion, we're going to stabilize the first Met and then assess for any hyper mobility that the patient has. I'd say her mobility is normal within 1 thumb length. So then with this, we're also going to passively assess this patient's dorsiflexion. So we're placing the fulcrum at the MTP. It's bisecting the first Met, and then we're bisecting the proximal phalanx and then applying force backwards. And we are at 40 degrees of dorsiflexion. Normal is between 70 and 90. So this patient is lacking some dorsiflexion of their first MTP. Next, moving on to the remaining ankle range of motion, we're going to be doing ankle dorsiflexion. So the fulcrum goes on the lateral malleolus. We're then having our stationary head go up to the fibular head, and then the movable arm is going to the 5th metatarsal. We are then going to have the patient pull their feet up, or their foot up. Assess. Can you relax? So stay there and then pull back for me. So this patient is at 20 degrees of dorsiflexion, and that is normal. And then for plantar flexion, we're going to start in neutral and then have the patient press their foot down. And this patient has 65 degrees of dorsiflexion. Normal is 50, so she has a little bit more range of motion with plantar flexion. Next is ankle eversion. So we're placing the fulcrum at the talocrural joint, bisecting the tibia, and then going to the 3rd metatarsal. We're then going to have the patient invert their foot. So this patient has a lot of inversion already just by observation. Yeah, she has 35 degrees of inversion. Normal is 20. And then going to have her evert her foot. And there she only has 10 degrees, which is normal. So she has excessive inversion and normal eversion. Next, we are going to do rear foot assessment in prone. So I'll have you lay on your back. So for this, we're assessing for subtalar neutral. So what I'm doing is I'm trying to find where the talar head is even on both sides. I'm doing that by inverting and everting the foot. So once I've found that the talus is equal on both sides, I then take my goniometer. The fulcrum goes on the superior calcaneus. The movable arm bisects the tibia, and the movable arm then bisects the calcaneus. And this patient has 4 degrees of rear foot varus, which that is normal. Normal is between 1 to 4 degrees. Next, for forefoot, what we're doing is we're assessing the fulcrum is at the calcaneus. We're assessing the patient's either varus or valgus at their forefoot, and she has 5 degrees of forefoot varus at her right forefoot. Then when assessing the first ray, we're seeing that if it's plantar flexed or dorsiflexed, it does not look that or appear to be that the patient's first ray has fallen because or in compensation for anything that's going on at the rear foot or the midfoot. Moving into weight bearing, we're going to have the patient come to the edge of the bed. So first off, I'm going to have her put her feet on the ground, and I'm assessing the height of the navicular. So I've already had it marked there, and then I'm going to have the patient stand up. And actually, just slightly. So then I'm assessing that drop using my little ruler. So she dropped 2.5 centimeters, which is a fair amount because normal is between 6 to 8 millimeters. So she has a large navicular drop going on. Next is assessing the windlass mechanism. So I will have you stand up for me. And what I'm doing with this is I am pulling the first ray back, and I'm assessing to see her arch raise up, and it does, so her windlass mechanism is intact. Next, assessing her calcaneus. If you could face the bed. So what I'm looking for is to see is her calcaneus inverted or everted while in weight bearing. So she has a normal calcaneal alignment. And also when assessing from back here, for the toe sign, she has 1.5 toes being observed on the right, while on the left, I can see 3 toes. So her left foot, her calcaneus is everted, and I can see a lot more toes, so her foot is kind of abducted. As from a sagittal plane, I do notice that the patient does have some knee hyperextension or genu recurvatum going on. And then also, she does not have any lumbar lordosis going on. And then I would also complete a gait analysis after doing all this. Thanks.